Let us start. All right. So again, you know, when we talk about diastolic dysfunction, you have to have some understanding of diastolic function. So when we're looking at heart function, we talk about a systolic function. That's when the heart contracts, and then a diastolic function, which we talk about relaxation and compliance. Um, and we went over uh, we look at the cardiac cycle. We look at the ECG portion of that, and we were able to, um, we said that diastole is from the end of the T wave to the QRS. And when we look at the Doppler, we know that diastole starts with IVRT, then you have your E velocity, you have your diastasis, and your A velocity. So, when you have a problem with diastolic function, then those things are going to be affected. We look at some additional parameters that will be affected if you have diastolic dysfunction. So, in addition to mitral inflow, okay, your E and your A velocity and your IVRT. We look at tissue Doppler imaging. We look at mitral annular velocity. And we said that one of the earliest things to be affected in diastolic, when you have diastolic dysfunction, is your E prime velocity. The E prime velocity gets smaller. And the current recommendation is a E prime less than 7 centimeters per second. So that is one of the updates. It's no longer less than 8, it's less than 7. So we're talking about 6 centimeters per second or less. And the EE prime ratio, which is also important, and it gives us information on left atrial pressure. That's the EE prime. You have a medial E prime, you have a lateral E prime, and then they have introduced an average E prime. So the average E prime is the medial and the lateral, you add them and you divide it by 2. So if your lateral E prime ratio is greater than 13, it suggests elevated left atrial pressure. If the average EE prime ratio is greater than 14, then that suggests elevated left atrial pressure. And then if the medial is greater than 15, it suggests elevated left atrial pressures. So a very high EE prime ratio suggests that the left atrial pressure is elevated. We also discuss pulmonary vein flow. And when you develop diastolic dysfunction, and if the diastolic dysfunction is getting more severe, then you will have diastolic predominance. Remember, the normal pulmonary vein flow, you have systolic dominance. But as the left atrial pressure goes up, then you'll have diastolic dominance. So we also look at that. Very important is left atrial volume and the left atrial volume index. And we went over how to assess left atrial volume index. The recommendation is that if the left atrial volume index is greater than 34 mLs per meter squared, then that suggests elevated left atrial volume. And well, not only elevated left atrial volume, but elevated left atrial pressure. It suggests that you have elevated left atrial pressure. When you're doing the left atrial volume, the method is called an area length method. You use a two-chamber view and you trace the left atrial border. You do the area and then you drop a perpendicular, that's the length. You do that in the two-chamber view, the apical two-chamber, and you also do it in the apical four-chamber view. The modern ultrasound machines will do the volumes for you, but if it does not, the formula is the area in the 2 times the area in the 4 divided by the shortest length, and you multiply that by 0.85, and that will give you the left atrial volume. To get the left atrial volume index, then you divide by the body surface area. In order to get the body surface area, you need the patient's weight and height, and you can use a normogram to give you the body surface area. Another important parameters that we use is the tricuspid regurgitation velocity, because if you think about it, when you develop diastolic dysfunction, and as the diastolic dysfunction gets more severe with elevated left atrial pressure, you're going to have some amount of tricuspid regurgitation. So a tricuspid regurgitation velocity greater than 2.8 meters per second is suggestive of elevated left atrial pressure. So the 4 things that you're going to look at first, there are 4 parameters that you're going to look at first. It is the E prime. Is the E prime less than 7 centimeters per second? The next thing you're going to look at is the EE prime ratio. And if you're using the average, is it greater than 14? The next thing you're going to look at is the left atrial volume index. Is it greater than 34 mLs per meter squared? And then the 4th thing is the tricuspid regurgitant velocity. So those are the 4 things you're going to look at first. Okay? For someone who has a normal left ventricular ejection fraction, someone with a normal left ventricular ejection fraction, those are the 4 things you're going to look at. Okay? And if 3 of those things are present, then you can make your diagnosis of diastolic dysfunction. And then after you make your diagnosis of diastolic dysfunction, the next thing is to grade it. So first, you make your diagnosis. Is diastolic dysfunction present, yes or no? If it's present, then you grade it. For diastolic dysfunction to be present, you need an E prime less than 7 centimeters per second. You need an EE prime ratio, if you're using the average, to be greater than 14. Left atrial volume index greater than 34. Tricuspid regurgitant velocity greater than 2.8 meters per second. If you have 3 out of those 4 things present, then the patient have diastolic dysfunction. All right, so the diagnosis of diastolic dysfunction in someone with normal left ventricular ejection fraction. Remember, when the patient comes with systolic dysfunction, when the patient comes with depressed left ventricular ejection fraction or reduced left ventricular ejection fraction, they already have diastolic dysfunction. Okay? Once the patient presents with depressed LV ejection fraction, they already have diastolic dysfunction. What we're talking about is someone with a normal ejection fraction. Again, you should take the age of the patient into account because, as we explained before, the older one gets, the more they rely on atrial filling, or the atrium to fill the left ventricle. So therefore, they're going to have problem with relaxation. So that is why the E velocity gets progressively smaller and the A velocity gets larger because they're dependent more on the atrial component to fill the ventricle. So in a healthy sedentary elderly patient, diastolic dysfunction appeared to be due in part to increased LV stiffness. Okay, and as mentioned before, the indices that are less age dependent is your EE prime. Okay, if your EE prime is greater than 14, it's rarely going to be in a normal individual. Changes in the mitral inflow velocity with Valsalva maneuver. Remember what we said, if you get more than 50% decrease in your E velocity, that's not gonna be due to aging, okay? And the difference in the duration between your pulmonary vein atrioreversive flow and your mitral atrial, the mitral A velocity. The difference in that duration is usually age independent. All right. So when we do or mitral inflow, okay, you get your E velocity, which is, of course, the suction effect. When the aortic valve close before the mitral valve is open, you have your IVRT, so the isovolumic relaxation time. Then the mitral valve opens and you get your suction or your rapid blood flow from the left atrium into the left ventricle, A velocity, and they get a diastasis, okay, where there's equalization of pressure between the atrium and the ventricle. Then the atrium contracts, okay. If you were to do your mitral annular velocity, then you get your S prime. I said the S prime is when the mitral annulus moves up towards the apex in systole, and then in diastole you have two components. You have an early and a late component. So it is this early component, this E prime, which is more sensitive to diastolic dysfunction. Okay, it is this component which is the early, and it's usually very high in a normal individual. The medial E prime is usually less than the lateral E prime. Again, as you know, this situation, so the lateral E prime is normally at least 12 centimeters per second. But they have introduced the average E prime. So it is the median, the lateral, you add them together and divide by 2. Okay, so that's the concept there. All right. As mentioned before, that the Valsalva maneuver can help to distinguish normal LV filling from pseudo-normal filling, right? So remember, one of the problem is when we have this pseudo-normal pattern, the mitral inflow. We know, as shown before, this is what a normal E. This is a mitral inflow. Your normal mitral inflow E is bigger than the A. But however, when you develop diastolic dysfunction, you will move from, say, a grade 1, where you have a small E and a big A, to grade 2, which is, a pseudo-normal pattern. So further into your diastolic dysfunction, you'll get a pseudo-normal pattern where your E and your A looks like it's normal, But if you do Valsalva maneuver, if you do the Valsalva maneuver, it will feed out, it will sort of ferret out those patients who have through diastolic dysfunction. You get a decrease in your E to A ratio greater than 50%. That's highly, for the Valsalva maneuver, when you'll get it will move from the pseudo-normal pattern to the pattern that you're more familiar with, which is a small e and a big A. So you get close to 50% reduction in the E velocity. So a decrease in the E to A ratio by 50% is highly specific for increased LV filling pressures and diastolic dysfunction. Okay, so when you do your Valsalva maneuver in someone with a pseudo-normal pattern, it looks normal, but you're not sure if this patient actually have diastolic dysfunction. The Valsalva maneuver will unmask the diastolic dysfunction. So you'll get a small E and a fairly big A. However, if the decrease in the E to A ratio is more than 50%, if the decrease in the E to A ratio with Valsalva maneuver is more than 50%, is highly specific for increased LV filling pressures and diastolic dysfunction. What you have to do is continuously record your mitral inflow using the pulse wave Doppler for about 10 seconds during the strain phase of the Valsalva maneuver. So you don't just say, bear down and let them bear down and hold it for at least 10 seconds. And you're going to record, let them hold it for more than 10 seconds, but you're going to record for at least 10 seconds to show that you get this decrease in the E. And if you do the E to A ratio, then if they have diastolic dysfunction and increased LV filling pressures, you're going to get more than 50% decrease in the ratio, the E to A ratio. Okay? So Valsalva maneuver can unmask diastolic dysfunction, especially in someone who was a pseudo-normal pattern. Okay? The reason why we call it pseudo-normal, because it looks normal. The E is bigger than the A, but it's not a true normal individual. That is why it's called pseudo-normal. Okay? All right. Also, we had mentioned increase in the pulmonary vein atrial reversal velocity duration versus the mitral A duration is consistent with increased left ventricular end diastolic pressure and diastolic dysfunction. So let me just remind you what we're talking about. Remember, when you have your pulmonary vein flow, you have your systolic component, and then you have your diastolic component, and you have your atrial flow reversal. That is why you guys need to constantly review these things. All right, so if this is the baseline right there, okay, so remember these are Dopplers. So you have your systolic component, pulmonary vein flow, your diastolic component, and this is your atrial flow reversal. Okay, let's call it AR. So remember, when the pulmonary vein is going to flow, blood is going to flow from the pulmonary vein into the left atrium. Okay, so in ventricular systole, blood is going to flow into the left atrium. In ventricular diastole, blood is still going to flow into the left atrium. But when the atrium contracts, it's going to push blood back into the pulmonary vein. And that is why you have this atrial reversal in the pulmonary vein. atrial flow reversal. It's going to have a velocity associated with it, and it's going to have a duration. Duration is the time that you have this atrial flow reversal. So this is the duration. And when you look at your mitral inflow, again, you have your E velocity. It doesn't go below the baseline, sorry. And then you have your A velocity. It doesn't go below that. So this is your E. And this is your A. Okay, the E velocity has a duration, A velocity also have a duration. The duration is from right there to right there. So what we're saying here is that increase in the pulmonary vein atrial reversal velocity duration versus the mitral A duration is consistent with increased left ventricular end diastolic pressure and diastolic dysfunction. So that if this, in the Valsalva maneuver, if you get an increase in this duration, this atrial reversal duration as compared to your mitral inflow, then that's suggestive or is consistent with the increased left ventricular end diastolic pressure and diastolic dysfunction. Okay? So that is what we're saying there with Valsalva maneuver. So again, with Valsalva maneuver, if you have a pseudo-normal pattern, then what you're going to get with the strain phase of the Valsalva maneuver, the E velocity is going to get smaller, okay? And if you look at if the patient really have diastolic dysfunction, elevated filling pressures, then the E to A ratios will decrease by more than 50%. And then when you look at your pulmonary vein flow atrial reversal velocity duration, that is this duration, increasing this duration versus the mitral A duration is consistent with elevated left ventricular end diastolic pressure and diastolic dysfunction. Okay, so you have to try and grasp that concept. All right, we'll answer the questions after the lecture. Remember, you're gonna have to, when you're doing these, you have to do at least a 10-second take. So, all right. So let's see. All right, so again, it's important to do these recordings properly. In case A, this is right there, these are mitral annular velocities, of course. And in A, the Doppler settings and sample volume location are optimal. So remember, it's your mitral annular velocity, and if you're doing the medial, you have to be right at the annulus, at the medial aspect. And you have your ECG on top, so you have your E prime and your A prime, and this is your S prime. Okay, S prime is right there. So it's important to look what you're doing. Don't just put your pointer and look away. It has to be at the medial aspect of the mitral annulus. So this is the correct way of doing it. In B, in sample B, the sample volume is placed in the ventricular septum, not the annulus. So if you can see it, it's placed way up into the ventricular septum. So it's going to decrease your S prime, and it's somewhat increase your E prime. So if it's not positioned properly, you're going to get erroneous values or numbers. And then in C, if you have a low gain, if if you have a low gain, then you're not going to see the stuff properly. And then in the with high filter. So the important point here is to make sure that the location is correct and your gain setting is optimal. If for the lateral mitral annulus velocity, again, proper positioning is important. It has to be at the lateral annulus. You don't want to put it in the basal segment of the lateral wall. You don't want to put it, sometimes you can put it outside of the heart. So make sure you put your sample volume at the correct position. Lest you're going to give the patient all sorts of diagnoses which don't really exist. So this is what we're talking about when you do the Valsalva maneuver. So this is a pseudo-normal pattern with a E larger than the A. Okay, so you may call this normal, but when you do the Valsalva maneuver and you do your recording for at least 10 seconds, okay, you can see the E, you have a decrease in the E, and the A, there's a slight increase in the A. But if you do your E to A ratio, the E to A ratio will decrease by more than 50%. So this is a patient with grade 2 diastolic dysfunction. And you see the E to A ratio at baseline is 1.3, and it decreased to 0.6, more than 50% with Valsalva maneuver. Okay? So the Valsalva maneuver will help to ferret out these patients with the so-called pseudonormal pattern. And usually these individuals will have grade 2 diastolic dysfunction. This pseudonormal pattern suggests that there's elevated filling pressures. So again, you continuous recording of the mitral inflow during the standard Valsalva maneuver, the strain phase for 10 seconds, showing the decrease in the E to A ratio with straining. Okay, so it's going to be a continuous recording. Okay, so you see the start out with a pseudonormal pattern, start the Valsalva maneuver, and you can see there's a gradual decrease in the E. Okay, which is consistent with elevated filling pressures. All right. The pulmonary arteriosystolic pressure can also identify patients with increased LV pressures. And we know that the normal, if you develop diastolic dysfunction, then because the heart is not emptying properly, the pressures is going to build up, and it's going to build up all the way to the pulmonary circuit. So the pulmonary arteriosystolic pressure will increase. Resting values are relatively age independent. So, pulmonary pressures don't go up with age. So we can use it. And that is why we talk about the tricuspid regurgitant velocity. Remember, you use your tricuspid regurgitant velocity to give you your pulmonary arteriosystolic pressure, 4V squared. Okay, so the number you need to remember is 2.8. So left atrial enlargement in the absence of chronic atrial arrhythmia. So we say the bigger the atrium, the bigger the left atrium, the worse the diastolic dysfunction. Okay, and the greater the left atrial pressure. So if you just think about it a little bit, if you think about it a little bit, if you think about it a little bit, if the LV is not relaxing properly, or if you have a problem with compliance, then because okay, if the left ventricle is stiff, let's put it simple. If the left ventricle is stiff, that pressure is going to back up all the way into the left atrium. And because the left atrium is now coming under pressure, it's going to get enlarged. So left atrial enlargement in the absence of atrial arrhythmia, because remember, atrial fibrillation can give you an enlarged left atrium because the left atrium is not contracting, blood stays in the left atrium and expand the left atrium. So in the absence of chronic atrial arrhythmia, it usually suggests that the patient have diastolic dysfunction. So if you see someone with a large left atrium, they don't have significant mitral regurgitation, they don't have mitral stenosis, they don't have any atrial arrhythmia, it's probably because of diastolic dysfunction. Pathologic LV hypertrophy. So when the left ventricle is thick, that's usually associated with increased stiffness and diastolic dysfunction. So, you know, those patients with very thick LV, the LV becomes stiff, and those patients will also have enlarged left atrium as well. All right, so this is all right. So this is a patient with a pseudo-normal pattern. So the mitral inflow. So on the left we have the mitral inflow, okay, and you have a big E and a small a. You know, so this could be normal, but it is really a pseudo-normal pattern. And the reason why we know it's a pseudo-normal pattern, when we look at our pulmonary vein flow, this is your pulmonary vein flow. And you have a systolic component, a diastolic component, and an atrial reversal. Okay? We know that in a normal individual, the systolic component is bigger than the diastolic component. In this scenario, the diastolic component is greater, suggesting that there's elevated left atrial pressure. So this, you cannot call this normal. This is a pseudo-normal, which is probably consistent with, well, in essence, well, a pseudo-normal pattern, probably grade 2 diastolic dysfunction. All right, so this is the mitral inflow and pulmonary vein flow from a patient with heart failure with reduced ejection fraction. So it is crucial to, because it is very important to know, because if the E to A is greater than 2, okay, listen carefully. If the E to A is greater than 2, this is restrictive physiology. So this is no longer a pseudo-normal. It is a restrictive physiology, and then this is what you expect, okay? So the E to A greater than 2, and you have reduced systolic to diastolic ratio in the pulmonary venous flow, okay? So these findings are consistent with elevated left atrial pressure. All right. So pseudo-normal or restrictive physiology. Remember the difference between pseudo-normal and restrictive physiology. Restrictive physiology, your E to A is going to be greater than 2. The ratio is going to be greater than 2. For pseudo-normal, your E is going to be greater than the A, but it's not going to be greater than 2. The ratio is less than 2 for the pseudo-normal. okay? But it also suggests elevated filling pressures. Restrictive physiology is worse in your diastolic dysfunction scheme than pseudonormal. All right. So when someone have a normal ejection fraction and they have heart failure, so we call those individuals heart failure with preserved ejection fraction. So patients with heart failure and a normal ejection fraction, we call them heart failure with preserved ejection fraction. So the ejection fraction is normal, but when you look at LV longitudinal function, it is impaired. LV longitudinal function is impaired. And what we mean by that is, remember, when the heart contracts, the mitral annulus moves up towards the apex of the heart. That is reduced, okay? And the LV longitudinal systolic function, you can use what we call MAPSI to assess that, which is the mitral annular plane systolic excursion. It is the same thing as TAPSI, but you do it at the mitral annular plane. Okay, it is an assessment of LV longitudinal systolic function, and that this is reduced in heart failure or patients, well, heart failure with preserved ejection fraction. Even though the ejection fraction is normal, MAPSI is going to be abnormal, mitral annular plane systolic excursion. So remember, MAPSI, this is a M mode measurement. It's a linear measurement. So the MAPSI is an M mode measurement. You can also get the same assessment using Doppler. You can use tissue Doppler derived mitral annular systolic velocity. So when you put your cursor on the medial mitral annulus, you press M mode and it will give you the excursion. If you take off M mode and you press your tissue Doppler button, it's going to give you tissue Doppler derived mitral annular systolic velocity, so-called S prime. So these are things that gonna give you LV longitudinal systolic function. Okay, so it is the medial mitral annulus that you put the cursor. Okay, and you can, as I say, you put the medial mitral annulus. You can press either the M mode button or your tissue Doppler button. M mode is a so-called MAPSI, mitral annular plane systolic excursion. This is a linear measurement because you're using the M mode. If you want to get a velocity, then that's when you use your tissue Doppler derived mitral annulus systolic. You get the S prime. Okay. You can also measure LV global longitudinal strain by speckle tracking echo. And when we do strain and strain rate, then we'll go over this. This is really very, very simple. So don't think strain is just change in length with respect to length. All right, it's just a change in length. So this is relative. It's not anything complicated. So what we'll go over is the LV global longitudinal strain, GLS, and it's best if you use speckle tracking echo. Less error if you use speckle tracking echo to do the assessment. So what we're saying is that patients who have normal ejection fraction and if they're in heart failure, in addition to all the diastolic abnormality, diastolic dysfunction, they're going to have a problem with MAPSI and S prime. Okay, so when you look at the mitral inflow in patients, some patients with elevated filling pressures, you're going to see the so-called L wave. And so the mitral inflow and the IVRT, okay, so this is the IVRT, from another patient with heart failure with preserved ejection fraction, heart rate 60. You can see that the E velocity is 96 centimeters per second, A velocity 65, and then you have this mid-diastolic flow. That is this thing right here, mid-diastolic flow. That's the L velocity. And it's present because of the slow and impaired LV relaxation and increased left atrial pressure. Okay? So when you see this, you think in terms of elevated left atrial pressure. Okay? So another case showing another L velocity. So it's a mitral flow. And it's the L velocity from a patient in sinus room, increased left atrial pressure. So when you see the L velocity, think in terms of elevated left atrial pressure. You can also see the L velocity in the mitral inflow. Okay, so you have your E and your A, and then you have this L velocity. Okay, so you can also see it in the mitral in your tissue Doppler velocity. All right, so now we come to the diagnosis of diastolic dysfunction. So the diagnosis of diastolic dysfunction in a patient with normal ejection fraction, the four variables that you need to remember is one, your mitral annular E prime velocity. If you're using the septal, it's less than 7. If you're using the lateral, less than 10 centimeters per second. So the first thing you're going to use, so all you need to do is look at 4 variables. So you look at the mitral, the mitral annular velocity, E prime. Okay? For septal, less than 7, lateral less than 10. Then you look at the ratio. If you're using the average E prime, then the E prime greater than 14. If you're using the lateral, then the EE prime greater than 13 is significant. If you're using the medial or the septal, then the EE prime greater than 15 is significant. Okay? Then the next thing you're going to look at is left atrial volume index. And if it's greater than 34 mLs per meter squared, so this is per meter squared, that's significant. And the tricuspid regurgitant peak velocity greater than 2.8 meters per second. These things are significant. So if you're going to diagnose diastolic dysfunction, you just need to look at 4 variables to start out with. Your mitral annular velocity, your EE prime, left atrial volume index, and the tricuspid peak velocity. Okay. Very important, your LV diastolic function is normal if more than half of the variables do not meet the cutoff values. So what we mean is that if 2 or more do not reach these cutoff variables, the patient will have diastolic dysfunction. All right? So in essence, you need 3 or more to move on. So that's what all this is saying. You need 3 positive variables to move on. So if LV diastolic dysfunction is present, then more than half of the variables meet the cutoff. So that means 3 or more. So if 3 or more meet the cutoff variables, then there is diastolic dysfunction. If that does not happen, the patient do not have diastolic dysfunction. So these are the variables that you're looking at. Your mitral annular E prime velocity, your E prime velocity, the ratio, E prime ratio, left atrial volume index, and your tricuspid peak velocity. And you have to know the values that go with those things. So for you to make a diagnosis of diastolic dysfunction, you need 3 of these variables to be positive. Okay. So you can look at, remember what we said, that when you have diastolic dysfunction, the worse the diastolic dysfunction, the greater the left atrial pressure, the greater the LV filling pressures. So you can assess LV filling pressures, and to assess LV filling pressures, you need to look at the mitral flow velocity. You need to look at the mitral inflow velocities, mitral inflow. You need to look at the mitral annular E prime velocities, your E prime ratio, the TR jet, and the left atrial maximum volume index. And again, I've been saying this over and over. If you have elevated filling pressures, then the usual thing, you probably get a pseudonormal pattern in your mitral inflow. You might also get a restrictive physiology where your E prime ratio is greater than 2. For elevated filling pressures, then you're going to have a very small E prime. We've established that. For elevated filling pressures, you're supposed to have a very high E prime ratio. If you're using the lateral, then greater than 13. If you're using the average, then it's greater than 14. And if you're using the medial, it's greater than 15. So elevated E prime ratio suggests elevated LV filling pressures. A very high TR peak velocity also suggests elevated filling pressures. And a very high left atrial volume index, a big left atrium, suggests elevated filling pressures. So you can look at these variables and come to some sort of understanding whether the LV filling pressure is elevated, yes or no. But you have to put it together. You can't just use one of them, and that is why you have to use them in combination. Okay? All right. So these are the main variables. Okay, and we talk about when these variables are abnormal and it suggests elevated filling pressures. But you can also use the pulmonary vein flow. Remember, we showed that the worse the diastolic dysfunction, the greater the left atrial pressure, the smaller the systolic component compared to the diastolic component, the pulmonary vein flow. So you can use this too. And you can also use the LV global longitudinal strain, the global longitudinal strain using speckle tracking echo. So these are supplemental things that you can use to show that there's elevated filling pressures. All right. Very important. In some situation, you can't just blindly use the variables that we talk about, because in someone with atrial fibrillation, you don't have at A, you don't have an A velocity. Okay, so you can't use your mitral inflow velocity if the patient have atrial fibrillation because you don't have an A velocity. If the patient have moderate mitral annular calcification or mitral stenosis, which is greater than moderate, you can't use your mitral inflow as well. So you can't say, well, let me use the E and then the E to A ratio, sorry, the E prime ratio. You can't do that. So the mitral inflow velocity sort of lose its value in patient with atrial fibrillation, moderate mitral annular calcification, patient with mitral stenosis, which is greater than moderate, more than moderate, mitral regurgitation, which is greater than moderate too. If the patient had previous mitral valve repair, mitral prosthetic valve, left ventricular assisted devices, patient have left bundle branch block, or ventricular pacemaker, you can't use the mitral inflow velocities. Very important. Okay, that is why you have all these supplemental things that I've been telling you. But there are other things you can use. You can use your mitral annular E prime. You can use your TR jet, your left atrial volume index. You can use your pulmonary vein flow, and then LV global longitudinal strain. Okay. All right. So a few other parameters. All right. So if your patient have an E to A ratio which is less than 0.8, so it's a small E, a big A, and if the peak E is less than 50 centimeters per second, then the mean left atrial pressure is normal or low, and you have a grade 1 diastolic dysfunction. So what I'm saying to you, you can do a quick eyeball. If the patient have a small E, a big A, and the ratio is less than 0.8, and if your E is less than 50 centimeters per second, or 0.5 meters per second, then the left atrial pressure is normal or low, and you have a grade 1 diastolic dysfunction straight off the bat. However, if the E to A ratio is greater than 2, this is what we call the restrictive physiology. E to A ratio greater than 2, your left atrial pressure is elevated, and this is your grade 3 diastolic dysfunction. So patient with restrictive physiology, where your E to A is greater than 2, left atrial pressure is elevating, it's a grade 3 diastolic dysfunction. So you should pick up by now that when you have an E to A greater than 2, that's what we call restrictive physiology. This is one of the worst stage of diastolic dysfunction, grade 3. However, E to A may be greater than 2 in normal young individuals, less than 40. So someone who's 20 and have an E to A ratio greater than 2, don't call them restrictive physiology because that's normal. However, if they're greater than 40, then that's probably restrictive physiology. So your E to A ratio is going to be age dependent. All right. Normal subjects usually have normal E prime. So it's very unusual to see a normal individual with a low E prime. You know, it don't work like that. All right. Another scenario, when you have a small E and a big A, but now your E, this is a mitral, your E is greater than 50 centimeters per second. Or if you have a pseudo-normal pattern, right? If you have a pseudo-normal pattern, you have to use the stuff that I told you about, okay? You have to use the stuff that I told you about. So you're going to have to use your TR jet if it's greater than 2.8, and then you use your EE prime ratio, LA maximum, you use the left atrial volume index, not velocity, volume index, and you can also use pulmonary vein flow to make your assessment. All right. So, but remember this scenario: a small e, a big A. If your E is less than 50 centimeter, you don't want to think, so left atrial pressure is normal, grade 1 diastolic dysfunction, and then these, restrictive physiology, and in a young individual with E2A, remember that. So outside of that, then you're going to apply what I'm going to tell you about now to determine the grade of the diastolic dysfunction. And this is the table. All right. So on top we have the grade of the diastolic dysfunction. So it could be normal, grade 1, grade 2, or grade 3. And then on your left-hand column, we have LV relaxation, left atrial pressure, E2A ratio, the average. So we use the average here, the average EE prime ratio, the peak TR velocity, and the left atrial volume index. So in a normal individual, you expect the LV relaxation to be normal. So the LV is going to relax normal. The left atrial pressure is going to be normal in a normal individual. In a normal individual, the E is usually bigger than the A, so the E to A ratio is usually greater than 0.8. And if you do your EE prime ratio, average that is. So you take the medial and the lateral, you add it together, divide by 2, and then you're going to put your E over the average E prime. If that average EE prime is less than 10, then it's probably individual is normal. The peak TR velocity is usually less than 2.8 as well. And your left atrial volume index is going to be normal. Patients with grade 1 diastolic dysfunction, they're going to have impairment in their LV relaxation. They have impaired LV relaxation. Left atrial pressure is going to be normal or low. And when you look at your E and your A, they're going to have a small E and a fairly big A. But your EE prime ratio using the average E prime is still going to be less than 10. Your peak TR velocity is going to be less than 2.8. So this is your grade 1. Your grade 2, they also have impaired relaxation, but the left atrial pressure is going to be high, it's elevated. The grade 2 is, some of them have what we call pseudo-normal pattern. Remember your pseudo-normal pattern, the E is bigger than the A, but some of them going to have small E as well. But a lot of these going to have pseudo-normal. But the E to A ratio is not going to get to the level of a restrictive physiology. Remember, with restrictive physiology, the E to A is greater than 2. So they're not going to, it's going to be less than 2, but it's, in a lot of cases, it's greater than 0.8. And then your average EE prime is a lot of times between 10 and 14. Your peak TR velocity going to be more than 2.8 meters per second. Left atrial volume index is going to be increased in your grade 2 diastolic dysfunction. And with your grade 3, these patients are going to have problem with relaxation. It's going to be impaired. They're going to have problem with compliance as well. Left atrial pressure is going to be very high. Your E to A ratio is going to be greater than 2 because that's a restrictive physiology. And your EE prime using the average E prime is going to be greater than 14. Your peak TR velocity is going to be more than 2.8. Your left atrial volume index is going to be increased. So when a patient comes to you, and you're assessing for diastolic dysfunction, this is how you're going to approach it. So the patient with normal ejection fraction, so remember, patients who have reduced ejection fraction, they all have diastolic dysfunction. But this is a patient with a normal ejection fraction. So when they come to you in the echo lab, you look at your 4 parameters that I spoke to you about. The average EE prime, if it's more than 14, your septal, that's a medial, E prime, if it's less than 7, or the lateral less than 10, if your TR velocity is more than 2.8, or the left atrial volume index is more than 34 mLs per meter squared, if they have 3 of these things, so they need 3 of these things to be abnormal before you can say they have diastolic dysfunction. If they have less than, if they have less than 2 or 2 or less, then they don't have diastolic dysfunction. Okay? If they have only 2, then it's sort of intermediate, and you don't want to say that they have diastolic dysfunction because they may not have it. So they need at least 3 of these parameters to be abnormal. Your EE prime, if you're going to use the septal, E prime should be less than 7. The lateral should be less than 10. TR velocity more than 2.8. Left atrial volume index greater than 34. So if they have 3 or more of these variables abnormal, then they have diastolic dysfunction. Okay? Then their next step is to grade it. So again, patient come to the echo lab, these are the 4 variables you're going to look for. Your EE prime, if you're going to use the average, then more than 14. If you can use the medial, but it's more than 15. The lateral, more than 13. Your E prime, if it's the medial E prime, less than 7 centimeters per second. The lateral, less than 10. TR velocity, more than 2.8 meters per second. And left atrial volume index, greater than 34 mLs per meter squared. For you to make a diagnosis of diastolic dysfunction, you need 3 of these variables to be abnormal. Okay? Then you have diastolic dysfunction. And then, so it's simple now. You just plug them into into your table. So if so the 3 variables are abnormal, and your E to A ratio is less than 0.8. Your E velocity is less than or equal to 50. Remember what we said about this? If the E is less than or equal to 50 centimeters per second, the left atrial pressure is normal. Remember we said that? Left atrial pressure is normal. If left atrial pressure is normal, this is a grade 1 diastolic dysfunction. No question asked. Grade 1. All right. So the next scenario, if the E to A is greater than or equal to 2, no question asked, restrictive physiology. So we know, because these are patients with diastolic dysfunction, and if your E to A is greater than or equal to 2, restrictive physiology, no question asked, elevated left atrial pressure, grade 3 diastolic dysfunction. You separate them. So you have this group now where you might have your pseudo-normal, or you might have the E being a little bit smaller than the A. So you look at your variables, okay? So you look at your variables closely. All right, so if 3 criteria, so these patients, so all our patients have diastolic dysfunction, because we already look at the 4 variables and classify them. We just have to grade them now. So these group of patients, okay, if they have EE prime average greater than 14, TR velocity greater than 2.8, left atrial volume index, then this is your grade 2. Your grade 2. Okay? Grade 2. All right? So I wouldn't get bogged down in anything else. But the essential thing is to once to make the diagnosis of diastolic dysfunction, you need to look at your 4 variables. You need 3 of them to be positive for the patient to have diastolic dysfunction. So these are the 4 variables. So if 3 of them are positive, the patient have diastolic dysfunction. Then you move to the next. If your E is less than 50 centimeters per second or 0.5 meters per second, and you have a small e, big A, then the left atrial pressure is normal. It's a grade 1. If they have restrictive physiology, E to A greater than or equal to 2, then they have elevated left atrial pressure, grade 3 diastolic dysfunction. Okay, and then the others more than likely going to have grade 2, because remember what we said when we look at our table in grade 2. Your grade 2 going to have elevated left atrial pressure. Your E to A ratio, even though it might be pseudonormal, it's still going to be less than 2, doesn't reach restrictive. The EE prime is going to be between 10 and 14. Your TR velocity is going to be greater than 2.8. So, all right, so you have to know, but the simple approach, use the simple approach. Does the patient have diastolic dysfunction, yes or no? Look at your 4 variables. If they have 3 variables positive, then they have diastolic dysfunction. Then the next step is to grade the diastolic dysfunction. Is it grade 1? Is it grade 2? Or is it grade 3? Okay. Again, grade 1 do not have elevated filling pressures. Okay, so your TR velocity may be less than 2.8. So I think we're gonna stop here and